case is on sympathetic ophthalmitis. It's a very rare complication of ocular trauma. So I've had the fortune to have two cases come to me. I'm just going to talk about those. Just a small overview. So it's a bilateral diffuse granulomatous uveitis. That's the definition. And it occurs to the good eye after a trauma or an intraocular surgery to the fellow eye. So the pathology, just a little bit, it's a type of autosensitization of ocular tissue following a perforating injury to one eye. So it's an immune response, basically. Okay. So the eye that is injured is the exciting eye, and the contralateral eye is called the sympathizing eye. So let's see the first case. There's this 32-year-old male. He was a gardener by profession, lower socioeconomic status, and he presented with a painful red eye, and he had photophobia, watering, blurring of vision, the typical. So his past history, he had a penetrating injury to the left eye with a thorn like 6 months ago. No other systemic illness. So obviously, when you know that you've had a trauma to one eye and the other eye is presenting like this, all red flags are going to go up. But that really doesn't mean that you have to ignore all other causes. You do have to work up this case like a normal uveitis case as well. So this is a clinical picture that we got. So the right eye BCVA was just hand movements and PR accurate. IUP was 38, and the anterior segment, you can see the pictures. I'll show you clearer pictures in the next slide. There were these mutton fat KPs, there was flare, pupil was fixed and dilated, there were multiple posterior synechiae, and the retina showed a lot of vitreous cells in the vitreous, optic disc edema, and there were focal serous retinal detachments. Had there not been a trauma in the other eye, looking at this, what would have been your obvious conclusion? What would your brain have gone to? Any suggestions? What would you think? Anything? Yeah, like so granulomatous uveitis, unilateral, and if there was no trauma and the retina is also showing these focal, serous detachments, you would be like, maybe it's VKH, right? So your brain would go towards VKH, which is, yeah, the most obvious DD for this. But the other eye looks like this, as you can see in the other picture. So now further red flags are going to start going up. So you can see the KPs, those mutton fat, typical bad KPs. And so we did a workup. See, just because there was a trauma doesn't mean you ignore it and be like automatically jump to conclusions, right? So we did the workup, we did all the blood investigation, CBC, CRP, ESR, the usual battery, VDRL, including serology, everything was normal. B scan was done. This is what we saw on B scan, okay? And we did an OCT macula also showing a serous detachment. So now we are thinking further. We did an FFA as well. Unfortunately, we don't have the images because our machine broke down. But the FFA had this very typical early phase, early phase, there were these leaks, pinpoint leaks initially, which then gradually expanded. And in the late phase, there was staining. So we made a clinical diagnosis of sympathetic ophthalmitis after ruling out all other possibilities. We cannot go to that diagnosis without ruling anything else out. Let's go to a second case. 50-year-old male, a plumber, presented with left eye, painless red eye, photophobia, watering, gradual progressive blurring of vision since 10 days. And he had a trauma to the right eye with a stone 5 months back. It was treated as a perforated corneal ulcer, no other systemic illnesses. So you can see the right eye, PL, PR, inaccurate, bad looking eye, and the left eye was looking like this, ciliary congestion, KP cells, typical again uveitic picture. However, in this case, we did see something else which was a little more interesting in the retina, something very textbook called Dalen-Fuchs nodules. Dalen-Fuchs nodules are these subretinal deposits, and they are not, we can't say they are pathognomonic, but they will lead you towards sympathetic ophthalmitis in the absence of anything else. You can be a little more confident with your diagnosis when you see something like this, and they light up beautifully on FFA as well. So yeah, FFA showed multiple diffuse punctate hyperfluorescent spots at the level of the RP in the early phase, which persisted with increase in hyperfluorescence in later phases. There was pooling of dye infrotemporally, which told me it's an exudative RD. The B scan showed a choroidal thickening with an exudative RD infrotemporally, and Again, after ruling out everything else with a thorough blood work, we made sure nothing else is there systemically, and we made the diagnosis of sympathetic ophthalmia. In both cases, we started the patient on steroids sufficiently early, sufficiently high dose. So we gave 80 mg per kg and gradual tapering, and the patient gradually made a wonderful recovery. He came back to 6.6 from 6.36. So, sympathetic ophthalmitis is nothing to be scared of. You don't see the case and be like, oh my God, this is hopeless. We can't do that. It is salvageable. We can bring the patients completely back. So, yeah, just a little overview. So, about in 1000 AD, one guy called Hippocrates, he said that in the right eye, which when diseased, often gives suffering to the left. This was a vague description of what sympathetic ophthalmia was thought to be about. So, in this, both eyes are affected. And now, is prevention better than cure? This is the most controversial question when it comes to sympathetic ophthalmitis. Should I enucleate? Should I not? But now we don't do that anymore because we are having much better forms of managing ocular trauma. Quick and careful surgical care of the wound, early proper closure of all penetrating wounds can prevent. Now, the incidence in 2011, the incidence of sympathetic ophthalmitis in case of trauma was 0.9. Today it's only 0.2. So that shows a long way that we have come, in preventing this devastating complication of ocular trauma. So, yeah, in eyes where no vision gain is possible, enucleation within 2 weeks after the injury can prevent SO, and delayed enucleation more than 2 weeks is not preventive. It's not going to help. You would have unnecessarily enucleated a patient. Yeah, corticosteroids. Use of steroids following the trauma before the development of sympathetic ophthalmia has seen to be of no use. So, unnecessarily pumping the patient full of steroids is also useless. Steroids are the mainstay after SO has set in, and anti-inflammatory action of the steroids is used to suppress the inflammation completely as soon as possible. Loading dose of IV steroids with tapering orally or high dose of oral, depending on the situation as you see fit. And subtenons, depot steroids may be added for posterior uveitis, and topical steroids as a marker for marked anterior uveitis. In addition, of course, mydriatic cycloplegics can be used. So now option 2, in patients where you cannot give steroids, you can try immunosuppressive agents like azathioprine, methotrexate, chlorambucil or cyclosporine. Definitely a full systemic workup has to be done before you start the patient on these things. It would be preferable to work in conjunction with a rheumatologist or an immunologist, somebody who can guide you on the dosages if we are not sure. Sympathetic ophthalmia is a serious vision threatening disease, but with modern therapy, there is plenty of hope for patients diagnosed with this. Even the exciting eye can have reasonable visual outcome with prompt and aggressive treatment. So, right now, in this day and age, sympathetic ophthalmia is not devastating, all is not lost. And I think with careful monitoring, we can bring the patients back to 6.6 like we did. Thank you.
Thank you, Aishwarya. What is the first sign of sympathetic ophthalmia? First sign? No.
KPs.
No. Homework. Huh? Even Parsons. Both. Any homework for you. One important thing I want to tell is I think we should remove the thinking of enucleation at all, because I am talking all the time vitrectomy for no PLI and no primary enucleation, no primary evisceration. No, primary.
I'm not happy with that.
No, falling. I told you, I appreciate it when I
lost,
produce thysis bulbi, then refer to you.
Yeah,
so then the patient is ready for
no
no family. When a child is injured, entire family is devastated. So the earliest sign is important to pick up. So for the sake of audience, the Parsons writes is the patient. I remember a 16-year-old following 4 vitreoretinal surgeries in Hinduja had a reading vision problem. The first thing will be the accommodation spasm. So that's the first sign. People miss it. You start aggressive treatment, and that's how they have now recoined, Dr. Narsingh Rao and JB, is a bilateral uveitis, the sympathetic ophthalmia. That's why they have removed the word ophthalmitis to sympathetic ophthalmia. So I think you have to pick up early and treat, And then second is no inoculation. And important while doing wound repair, particularly posterior to the cord, like even the scleral tear, you make sure that no uveal tissue is in the in the tissue. So wash well, and probably you can use viscoelastic to push the material if it is a fresh wound.
Minimal handling of uveal tissue as possible.
Yeah, that's right.
Also, you have to sort of see that you reach the farthest end of the scleral tear. Yeah, I mean, you suture this, otherwise you'll land up with chronic hypertonia or whatever. I wanted to ask you, what about the use of Ozurdex in a case of sympathetic ophthalmia, in case a patient is a diabetic?
It takes way too long to act. I mean, by the time we can get any response from Ozurdex, I think patient would have oral steroids and
Oral
IV
steroids, then in that case, if you want a faster this, would you consider methylprednisolone?
Yes, absolutely. If it's a very fulminant kind of anterior uveitis, we generally start off with
1
3
gram
days of IVMP
for 3 days.
and then go into the oral steroids. That will give
Okay.
you faster results.
But if a patient is an uncontrolled diabetic, then also you would think in terms
We
of
have
this.
to, because it's like a pros versus cons situation.
No,
But
with
yeah,
the
endocrinologist,
diabetologist.
yeah, we collaborate with an endocrinologist and ask
Okay.
him to up the insulin or give an infusion of insulin while this is going on.
Okay, fine. Thank you.
Thank you,
Any
Aisha. Can
other
I have the
questions from
speakers and
audience?
Dr. Naresh? We can have a photograph. Dr. Ayantika, you can take the photo and
Anyone
send to us.
has any questions
And we
for
have,
Aishwarya?
I'm happy, we
Yeah,
have Dr.
please.
Santosh Mahapatra.
She
Yes,
has
madam.
a question.
Yes. No, so in under systemic monitoring, if you're giving IV steroids, better to get the patient admitted, give IV methylpred, first 3 days loading dose, and then go on to an oral tapering. If the uveitis is not so fulminant, you can start off straight away with oral steroids itself, along with a pantoprazole and a calcium supplement. And if the patient is a diabetic, consult an endocrinologist to monitor the sugars.
And also antimitotic drugs will help if you pick up the uveitis early, start steroid, then supplement with the antimitotic drugs
Methotrexate would be the best bet.
so that you can. So we have a
Intensive course.
next instruction course is also on trauma. Dr. Santosh, we'll have a group photo and then you can take over. So can you have the speakers and Dr. Naresh?